Assalamu alaikum. Good morning, everybody. Today we have our tele-NICU from Al-Qasmi hospital. It will be about to treat or not to treat the preterm baby with a PDA. It is a hot topic as usual, this issue. Dr. Hayam, she's inshallah, she will be a consultant soon. Inshallah, she's our specialist second on call neonatologist. She's going to present. The floor for you, Dr. Hayam.
Assalamu alaikum. Actually, the topic today is like discussion rather than presentation because there is no clear cut to treat PDA or not to treat PDA in extreme history, epidemiology, embryological background, pathophysiology, clinical researches, conclusion, and references. By history, in 1938, the PDA was the first congenital heart lesion that was surgically repaired, and this was done by Dr. Robert Cross. In 1963, which is almost 30 years back, closure of PDA in preterm neonates with respiratory distress syndrome was first detailed by Dr. Melpau. In 1989, Krishenko et al. And geographically classified the PDA based on the ductal, lumen, at the aorta, at the pulmonary end. Nowadays, with the increased survival of preterm population, the issue of closure PDA also increased, and it's always kept under observation and close monitoring. The incidence that all we know that PDA is related to gestational age. The younger the gestational age, the higher the incidence of patent ductus arteriosus. So in general, PDA is the most common cardiac condition found in neonates. Below 24 weeks of gestation, we have like 90% patent ductus arteriosus. Between 25 to 28 weeks, 80% of infants have patent ductus arteriosus. 10% of neonates born between 30 to 37 weeks have PDA till day 4 of life. We know usually term baby will be closed within the first 24 hours. Even after 28 weeks of gestation, expected to close spontaneously. There was actually an interesting study here I did not mention in the presentation, but maybe it could be beneficial to know that like 78 to 84%, more than 28 weeks gestation, it will close spontaneously, maybe later than 4 days, but it will close up to 84%. As we know, the fetal circulation, the pulmonary vascular resistance is high, and in comparison to placental vascular resistance, and blood going bypass the pulmonary, the lung, and the high resistance, pulmonary vascular resistance to from right side to the left side through the ductus arteriosus. Ductus arteriosus reserves the right ventricular function in utero. That's why if the duct closed prematurely, this will cause too much load on the heart, causing to in utero heart failure, and can present with fetal hydrops. After birth, the things changed since we start clamping the cord, and the placental flow almost diminished, and the baby take the first breath. At the same time, the vascular resistance reduced, and the placental bed actually closed, and the systemic vascular resistance increased. So that we go from fetal circulation to normal circulation. At that time, the PDA is responsible for over-circulation because shift from left to right. So the lung will be flooded more. This will affect the volume overload on the heart and the lung. With its complication, we can discuss it in details, and also systemic hypoperfusion, because this part of the blood going from the systemic circulation to pulmonary circulation, leading to systemic hypoperfusion, which can complicate later on with necrotizing enterocolitis, the most serious and common also complication of patent ductus arteriosus. Patent ductus arteriosus causes pulmonary overcirculation, as you mentioned. Will present with pulmonary edema, pulmonary hemorrhage, even sometimes, reduce lung compliance, and increase parameters on the ventilator and make it ineffective gas exchange. And we saw this on our daily clinical practice every day. The baby is stable, and then the ducts open or reopen, and again we cannot wean the baby from the ventilator. We increase the ventilation parameters. Prolonged ventilation causes parenchymal lung damage in neonates. PDA closure within the first 4 weeks of life may allow for faster weaning of oxygen and ventilator support in extreme low pulse weight, of course, and reduce bronchopulmonary dysplasia as a result. So the question is, should we treat PDA or not to treat PDA in preterm infant as a normal physiology going with closure? Actually, this question is a very big question. I tried for the last 4 weeks to find an answer for that. Unfortunately, I couldn't. There is no universal consensus about this. We come to some detailed papers. Actually, I found this paper. It is published in February 2021. It is considering management of ductus arteriosus in preterm infants in 2020. This was University of Tennessee in the United States. Again, the decision to treat PDA is still strongly debated among cardiologists, neonatologists, and cardiac surgeons because of there is a lack of strong evidence that support mainly the long-term sequelae. Practice vary from center to center, and still local protocol is different from center to center, from country to country, and is still controversial. So should we treat PDA or not to treat PDA? The answer will be coming with treat hemodynamically significant PDA, which will take us to the second question, what is hemodynamically significant PDA? Unfortunately, still, there is no universal a lot of parameters to be checked by echocardiography. So, as we know all, that PDA is associated with multiple morbidities, which is IVH, necrotizing enterocolitis, retinopathy of prematurity, and bronchopulmonary dysplasia. In the 21st century, almost all PDA were assumed to be hemodynamically significant, and physicians aim to close it as soon as possible after birth. Recently, even before that, actually, if you go all the history, it was the first choice. It was surgical repair, which is actually found to be with very high complication and morbidity. That's why it's not an acceptable practice anymore. There is no surgical closure unless it is indicated. It cannot be done just because of the duct is patent and open. So the trend now, or the approach mainly by most of the physicians, is going to watch and wait approach. And in one of the studies, actually, we found that from 60% to 74% up to 2014, this is cases, the downward, the percentage of babies that went to a closure of PDA medically, actually, they reduced from 60% to 74%. This is through 2008 to 2014. Still, there is a lack of quantifiable improvement in outcome after PDA closure, likely influenced this practice changes. That's why they cannot find difference, significant quantifiable improvement in the late outcome after PDA closure. The outcomes without noticeable improvement after PDA closure include bronchopulmonary dysplasia, necrotizing enterocolitis, IVH, and the retinopathy of prematurity, periventricular leukomalacia. And the most important thing is a long-term neurodevelopmental status and death. Actually, what's found interesting that we know that PDA closure definitely will reduce the risk of IVH and severe form of IVH. But it is found that at the age of 2 years, still neurodevelopmental, it's not, outcome is not improving. And still, this is again raising the question, is this neurodevelopmental issue related to the IVH, related to closure of PDA or not? This is still a question need to be answered. So according to echocardiography criteria, it is assumed that hemodynamically significant PDA, one of the major criteria to consider PDA closure, and it is echocardiography parameters. Transluminal diameter should be more than 1.5 to 2 millimeter, and or one of the following criteria, which is continuous flow through the ductus arteriosus, or retrograde diastolic flow in the descending aorta, or dilatation of the left atrium, which is the LA to AO ratio more than 1.5 millimeter, and also the ductus size ratio to the descending aorta more than 0.5 millimeter. And by echo also, echo it's the only confirmed way to discuss or to acknowledge that the PDA is hemodynamically significant. And any picture of overload on the so transductal diameter, evidence of left-sided volume overload, quantification of ductal shunting, and magnitude of pulmonary overcirculation. Of course, the clinical judgment here playing a role with the, as we mentioned, that the baby is like increasing the ventilation parameters or difficult to wean or signs of hypoventilation. And nowadays we can monitor it very near. And regarding also, it will be good the parameters to anticipate for necrotizing enterocolitis in such cases. Again, we discussed now the closure of PDA. Is it prophylactic? So we will do it for all the patients, or it is symptomatic or surgical. So prophylactic medical closure of hemodynamically significant PDA to moderate to large PDA have been associated with morbidity, that we know that moderate to large has been linked to morbidity in more than 60 controlled trials, yet lack of any decrease in morbidity and mortality after the ductal closure has still questioned the utility of use of prophylactic PDA closure in preterm infants. Why do you think that closure, we don't have evidence-based, we don't have evidence that closure is linked to the improvement in the late outcome or in the recent outcome, as we mentioned, IVH and BVD and necrotizing enterocolitis type 2A especially. This is assumed by one of the scientists, I think the name is McNamara. He assumed this because of 4 reasons. The first reason that hemodynamically significant PDA, it's no true causal relationship with adverse outcome. So this adverse outcome may be for another reason. It's not linked specifically to hemodynamically significant PDA. The second reason could be the variable definition of hemodynamically significant PDA. We don't know exactly, there is no consensus about that, which one is significant and should be treated and which one is not. And this will take us about, for the third reason, this crossover between placebo and treatment group may have obscured and visible benefits. The fourth reason, that there is a causal relationship between hemodynamically significant PDA and adverse outcome, but closure alone will not fully ameliorate morbidities or mortality. And also multiple confounding factors, of course, for extreme preterm. And they believe that the hemodynamically non-significant PDA is diluting statistically wise the data, and that's why we cannot reach to consensus about that. So these 4 reasons explain why we don't have a clear data to support our decision. So prophylactic medical closure of PDA is still the decrease, it will decrease the incidence of severe IVH, but it's not translated into enhanced neurodevelopmental outcome in the long term. We don't know. Common sense, if I reduce the risk of IVH, I expect the neurodevelopmental outcome is improving, but this is not the case. So the MENTO trial done in 1994 showed very favorable neurodevelopmental outcome in 4.5 and 8 years old children who were treated with indomethacin prophylaxis. This is one of the trials. But PDA tolerate trial found medical treatment after the first week of life was not associated with reduced PDA ligation or PDA present at discharge in infants born before 28th of gestation. And it is found that also early medical closure of PDA is associated with increased risk of late onset sepsis between 28 to 8 weeks gestation when exposed to early medical treatment. And this will carry also will raise the question of side effect of medical treatment, which is ibuprofen, indomethacin, and paracetamol. So a survey done in 2018 between neonatologists and cardiologists concerning PDA management, and we found that the cardiologist found that the PDA closure altered the clinical outcome in infant born less than 28. So for extreme, the cardiologist going with closure. But in this survey, half of the neonatologists disagree with this statement. So again, currently no enough evidence. So whether systemic complication associated with PDA in extreme low birth weight infant is due to the PDA or simply as a result of prematurity, we don't know. Actually, in this paper, which is published in PMC Pediatric in 2018, there was like a multi-center randomized non-inferiority trial covering Europe from 2004 to 2014 regarding the treatment versus expectative management. So to treat or to wait conservatively or watch and wait approach. It is very interesting. The population in this study, it was gestational age group below 28 weeks, confirmed echocardiography about the PDA transductal diameters more than 1.5. This is the inclusion criteria. And the treatment was supposed to be early treatment between 24 to 72 hours of life with COX inhibitors or cyclooxygenase inhibitor, ibuprofen, versus no intervention at all. The first outcome, the exclusion criteria, actually any baby who is having another reason like congenital heart disease or any baby who received ibuprofen for another reason. And also babies who have contraindication for medical treatment, this all was excluded. So the primary outcome was mortality and or necrotizing enterocolitis more than 2A stage according to Pell staging or bronchopulmonary dysplasia. This was the primary outcome. The secondary outcome was cardiovascular compromise, any picture of heart failure or another comorbidity and adverse events during hospitalization, and long-term neurodevelopmental outcome assessed at the age of 2 years. In this table, actually, it is showing the placebo versus babies who received COX inhibitors. We can see the number of studies. This is a huge study, actually. And with this all numbers, we reached to 334 babies. We don't have the consensus data or strong data to support one of the decisions. We can see the IVH from the risk ratio is 0.98, which is quite high. The mortality is the same. Bronchopulmonary dysplasia, actually, according to the study, some studies consider it at the need of oxygen at the age of 36 weeks post-menstrual or after 28 days of life, either this or that. We can see here the number of data collected from 2004, from 1981 up to 2014. This is a percentage of patients, which is control group, eventually treated for their PDA. So with this all studies, there is no relation has been proven between hemodynamically significant PDA and neonatal complication related to pulmonary hypertension and or systemic hypoperfusion. Although the result is conflicting in many papers, but still there is a lot of lessons to be learned here. So a common understanding is that medical or surgical treatment of PDA does not seem to reduce the risk of major neonatal morbidity or mortality. Either we close it or not, still we don't have understanding for the major mortality and morbidity affecting the baby, especially the neurodevelopmental outcome. As we know that the PDA might have been closed spontaneously, treated children are not potentially exposed to iatrogenic, are exposed to iatrogenic adverse effects. So if these babies, eventually the PDA will close, why we should treat and carry the rest of adverse effects of the medication, especially indomethacin and ibuprofen. That's why the conservative approach is gaining more interest worldwide, and most of the neonatologists going towards wait and watch approach regarding the PDA closure, but still we don't have enough evidence to support this approach. In this study, actually, it's 2022, the Canadian Pediatric Society gave the recommendation about management of PDA. Actually, I tried to tackle all the reputable center. We check Canadian Pediatric Society, we check American Academy of Pediatrics. So let us go for the Canadian Society. They advise that prophylaxis with IV indomethacin in extreme low birth weight infant may reduce severe IVH. There was agreement on that. Echo should be routinely done for every baby before starting symptomatic treatment. Asymptomatic PDA can be managed conservatively. So still, this is a clinical judgment. If the baby is stable, we can wait and see. We can treat him conservatively with fluid restriction or diuretics and wait and see. In Canadian society, actually, they consider the ibuprofen the drug of choice in treatment symptomatic PDA. And they recommend even high dose of profen. Usually we are giving course of 3 days, starting with 10 milligram per kg per day, and then next day 5 and 5. But if it is failed, which is considered 2 courses, and still the PDA is still open, we can go to higher dose of ibuprofen. And what's interesting that the oral ibuprofen, it is found to be more effective rather than the IV. Procedural closure, which means transcutaneous closure of PDA rather than the surgical ligation, may be considered for infant with persistent PDA with significant clinical symptoms, in addition to echo signs, of course, of large PDA and pulmonary circulation overload and systemic hyperperfusion at the same time. Actually, percutaneous closure now, it's more preferable rather than the surgical intervention because of the less morbidity and mortality. Here, the American Academy of Pediatrics regarding the treatment again of PDA. They didn't add too much actually, but we can see this a large body of evidence now demonstrate that early routine induced closure of PDA in preterm infant during the first 2 weeks of life does not improve long-term outcome. This is class 1A evidence, so it is very strong evidence. So the PDA closure will not improve the neurodevelopmental outcome on the long run. But selective use of medical induction of ductal closure, either for defined high-risk infant in the first 2 weeks postnatally, or more generally for all the infant that with persistent PDA, remain uncertain and require further study. Here, actually, it is very large also study regarding if we decide to treat, which one to choose, which treatment to choose, paracetamol versus ibuprofen in preterm infant. It is found that it is non-inferiority randomized clinical trials with a lot of data here. It is a non-inferiority randomized multi-center double-blind study to evaluate the efficacy and safety of intravenous paracetamol versus intravenous ibuprofen. It is actually done in multi-centers. All of them are level 3 in ICU. So the primary outcome was, or study point was the closure of PDA after the first course. And the secondary outcome was effectiveness, need of second course, rescue treatment, reopening rate, time of definitive closure, and need of surgical ligation and safety. if you go one by one, from my side, actually, we believe at a point in our practices, always ibuprofen is superior for paracetamol, but what is found here, it is actually almost all of the study, the paracetamol is higher than the ibuprofen. Based on data in this randomized clinical trial comparing paracetamol to standard treatment, paracetamol appeared to have promising clinical results with a low rate of side effects. A systemic review published in 2016 by Terrain et al. Induced two randomized clinical trials and 14 uncontrolled studies found that no difference in the rate of ductal closure when paracetamol was used in the place of ibuprofen. Sorry, it's missing here. Safety profile, paracetamol and ibuprofen were similar. It's not like we used to believe that ibuprofen is worse. Indomethacin is worse, this is proved, but ibuprofen and paracetamol, they are almost similar efficacy and the same regarding the side effect. In 2018, also, Hang et al. Published a 5 randomized controlled trial, including a total of 677 units treated with either paracetamol or ibuprofen. The rate of and overall PDA closure were similar. So paracetamol and ibuprofen, they are almost the same. The only thing interesting here, it was a high dose of ibuprofen in the failure rate or resistant PDA. And also the oral is more effective rather than the IV, but again, the question here about the expected side effect on the GIT, and if there is another contraindication, like the baby has deranged renal function, high potassium, low platelets, so the choice will be always tailored to case per case. So conclusion-wise, PDA is the most common pediatric condition affecting premature neonates. Management of PDA continue to be a challenge for neonatologists and pediatric cardiologists. And after 50 years of scientific investigation yielding thousands of publications, there is still no agreement on definition of hemodynamically significant PDA or how best to treat it. However, these clinical lessons, there is a lot of clinical lessons just put under consideration and brought into light, cannot be ignored, which is routine PDA closure soon after birth does not diminish the morbidity associated with a PDA. Surgical ligation has been associated with higher occurrence of BBD, ROP, and poorer neurodevelopmental outcome. Percutaneous PDA closure, in spite of being less invasive, still the risk remains, but definitely it is less than the surgical intervention. Medical closure of hemodynamically significant PDA has positive results for sure, but still we are still facing the medication side effect or iatrogenic, we consider it iatrogenic harm. So continued question of who needs intervention for hemodynamically significant PDA and how best to achieve this still, while minimizing the morbidity and mortality at the same time, specifically in premature infant population. So exploration, adaptation to our theories about PDA is still needed and recommended. And this is my reference. Thank you.
Thank you, Doctora.
I didn't get an answer still for we should treat or not, so we will debate this every day. Yeah.
Thank you, Doctora.
This update, what we do still.
Yes, with this all, yeah. Actually, I found a lot of papers. I did not present it all, but I was trying to find an answer, but it is no. So clinical judgments. Eye of expert making a big difference. If you are seeing your patient every day, you can judge this baby is deteriorating today because of the volume overload or systemic hyperperfusion. And we meet this every day. Thanks a lot for listening. Any questions?
مرحبا أنا الدكتورة آمنة.
أهلا دكتور.
Thank you for your comprehensive lecture. It was It was excellent lecture. Just I will add a comment that the PDA management go through a lot of stages. So initially, when I was resident, they said prophylaxis management when we are resident. Then it goes through the hemodynamically stable or non-stable and the ECOs. Dynamic or hemodynamic patients and symptomatic or non-symptomatic, and we go with that. Nowadays, what we are doing is the target PDA management. What we mean by target, there is target populations and target criteria. So we are doing echo, early echo within the first 24 hours. Just 1 minute. Okay, so what we are doing, yes, please. What we are doing is we target PDA. So we are doing echo early within the first 24 hours, and then there is criteria for the PDA. So we look to the size of the PDA, we look to the flow of the PDA, we look if there is stealing phenomena, and maybe there's 5 scoring system. And according to this score, if it's high score, highly significant, we go with the early treatment. Now, the question early or paracetamol or ibuprofen is also depend on the patients. If the patient having thrombocytopenia, renal insufficiency, gut problems, so we go more for the safety medication like paracetamol. But if there is no contraindication, we go with ibuprofen. I know from the study it did not show, and for us it showed that easy to extubate the patient, easy to keep him on non-invasive or on CPAP, easy to pursue the feeding with him. If it's significant PDA, we end with a lot of complication with pulmonary hemorrhage and increasing the IDH because of hemodynamically instability of the patients. So again, maybe different opinion, each neonatologist having different way or different approach, and you will not find anyone having the same agreement. But what we are practicing now is target PDA. We target certain population less than 28 weeks, and there is a score system going through that. Share the article with anyone interested. Thank you.
Thanks, Doctor. And actually, you summarized the presentation. I was actually surprised when I found out that the surgical closure was a practice, like a routine practice in the late 80s, which is changing tremendously nowadays. And it is recommended recently to do to confirm the BDA, presence of BDA, and with the criteria of significantly BDA with echo in the first 24 hours in the extreme preterm, and treatment as early treatment considered in the first from 24 hours to 72 hours. And actually, this is exactly what we are doing, and we tailor the choice between paracetamol and ibuprofen. Both of them actually is FDA approved. And if there is no contraindication, in our unit now, the practice we are using the paracetamol as a first choice. And as we said in the presentation, the efficacy, it is similar, but still for ibuprofen, you have contraindication. If the range of renal function or low platelets or GIT symptoms, it's not a proper choice. So we go for paracetamol. Thank you.
Thank you, Doctora. Thank you.
Can I comment? Assalamu alaikum. Thank you, Dr. Hayam. It is really extensive review, what you have done actually. And just to mention something regarding the evidence, as you said, it clearly mentioned that what has been shown in the studies, because these are the data collected from very old studies. So even what you have mentioned in the presentation regarding McNamara group, that why there is the data didn't show that much improvement, although we are closing the PDA. So the work which has been done with McNamara in his center, it has been the problem of the exposure. So the time of the PDA exposure to this preterm baby. So how much time the baby is exposed to the huge PDA is the problem of causing the side effects. So if you targetedly treated the hemodynamically significant PDA that is from the beginning is really huge and causing a tremendous effect on the baby. Yeah, if you target it from the beginning very early and you try to close it very early, even in McNamara group, it has been shown that decrease the BVD, decrease the IVH, decrease the neck. It was really interesting what has been done by them. And again, as you said, it is from center to center. So in our in Al-Qasimi hospital, there was an issue with us before, especially regarding the pulmonary hemorrhage. And it was really significant improvement when we start to treat the hemodynamically significant PDA. We are seeing now pulmonary hemorrhage, which was being seen, which we used to see it a bit frequent in the extreme group. So yes, there is a huge, let us say, controversy, but still it is from center to center, and every center has to check what is their problems and need to target it. Thank you so much.
Clinical judgment is very important also. Thanks.
Yeah, thank you, Dr. Hayam. Nice presentation as usual. So I'd like to highlight a few things here in your presentation and just the comments of the colleagues. First, we have to keep in mind that, as mentioned in the presentation, the size of the PDA is not enough. There should be something like we should know about the size of the shunt and how much is hemodynamically significant. Now, the other dilemma, what do we mean by hemodynamically significant? I'd like to share this question later to Dr. Khalid. If he can comment on that, he would know better than me. The second thing, whatever we say about the IVH, about the PVL, about the ROP, about the neck, our ultimate goal is the morbidity, the long-term morbidity and mortality for these babies. So still, we are not showing that good evidence that treatment of every single PDA or most of the PDA, let's put it this way, is making a difference. So far, we don't have that evidence. Now we have to think of the side effect, as mentioned about the platelets, renal function, all this stuff. So we have to think twice before considering treatment for these babies. The other things I'd like to highlight also about the oral ibuprofen. The studies showed oral ibuprofen is giving higher level and more consistent level over 24 hours. So I think we should go back to oral ibuprofen rather than, and again, I support the CTS statement regarding the ibuprofen as a first choice. The paracetamol is kind of reassuring for us, but it's we don't have enough studies about how much it's effective. There are 2 or 3 randomized trials comparing paracetamol to ibuprofen, but I don't think this should make us putting paracetamol ahead of ibuprofen. The number of studies has been done for ibuprofen is much more than paracetamol. Considering also the dosage, there is a lot of changes now has been done. At least I think 3 randomized trials, mostly in Canada, has suggested higher doses. So there is a regimen that you can follow. There is a very early treatment, which is the first 3 days, and then the early treatment, which is 3 to 7 days, and then the late treatment. And for each time period, we have a different regimen. Like the first one, we have the 7.5, and in the third one, we have the 20, 10, 10. This showed a better improvement in or closure, let's say, in these 3 randomized trials. Also, we have to be cautious about interpreting the non-inferiority trial. We have to keep in mind that non-inferiority trial is not as equal as the randomized trial. So we have to be cautious. I have seen, I think, 2 or 3 studies. Non-inferiority trial, we should not consider this as good or as valuable as the randomized trial. So we have to be cautious interpreting these results. The last thing I will leave you with the approach have been studied or discussed in the last Pan-American discussion, the hemodynamic, biomedical and hemodynamic group, probably last month. And I like their approach. First of all, we have to see if the PDA is hemodynamic significant or not. And second, we have to, as Dr. Anna mentioned, we have to target what age group we have seen. There is almost agreement that hemodynamically significant PDA in babies less than 26 weeks should almost always be treated. Above this age, we have to think more or think twice before that. The second approach, after we decide the treatment, what medication we should use. And again, I'm in favor of ibuprofen. The third question is what's the appropriate dosage? Even for the paracetamol, there is no standard dosage now. Some people, they use 15, some people, they use 20. So we have to think of the dosage as well. And again, ultimately, how much we are going to benefit these babies from treating these PDA. So these are just few points I wanted to highlight with the Dr. Hayam presentation. I'm not sure if Dr. Khalid has any comment and helping us in deciding what do we mean by hemodynamically significant PDA. Dr. Khalid?
Dr. Khalid, you still mute.
He's with us. Yeah.
But he's mute.
Dr. Khalid?
His mic is mute. She is unmute.
Yeah. No?
Tell Dr. Khalid, first of all, I want to thank Dr. Hayam for this presentation. Second, most important that with treatment, we need to be careful about the side effects. And this we need to look at. Recently, there was a small study done by Dr. Afif capacity in Irlanda. They mentioned that when they give paracetamol early, they found those people will have persistent pulmonary hypertension. Early closure associated with persistent pulmonary hypertension. Whether there's some correlation is there or not, still the study with small number, they are doing more advanced studies, they are looking at it. But this guy and his center in Irlanda, they are targeting PDA as early as possible. They are treating all cases, they are doing it. And contrary, our Richard Borrell in Columbia University, USA, they are not looking at PDA. And Dr. Yasser knows this part, even when he's sitting and speaking about PDA treatment in many conferences I attended with him, he's always saying that they are not looking at it and they are not even treating the PDA. Although their outcome as regard the BPD, as regard other treatment, IVH, for example, it is good. According to what his center experienced, but still again, and we are always connected, it is center by center, it is actually. And what we are looking here with actually with Dr. Mira, that we are targeting a certain group of babies, treating them no response. We need to give one course, second course, if no response, maximum 3 courses, and if no response, we need to go for PDA medication. This is
because I was on another committee meeting. Thanks Hayam for the presentation. Just to highlight a few points that and thanks to Yasser for the comments regarding the choice between the ibuprofen and the paracetamol. Actually, for the first choice for us is the ibuprofen, but we noticed like a good number of the cases they developed the GI issues, so we couldn't continue the ibuprofen. And we got, I think, 1 or 2 cases so they developed perforation. From that, we changed the practice to start with the paracetamol, and actually we got a good response to the paracetamol. And this, the baby had like not responded to the paracetamol, no contraindication. The second course would go the ibuprofen. So that's why. But before we moved the ibuprofen as the first choice, but we changed according to the findings.
Yeah, according to the evidence, yes, paracetamol is as effective as ibuprofen, and but the new thing for me, at least, that the new higher dose. We can go if we have like 2 courses failed of treatment of closure, we will go to a higher dose of ibuprofen. And oral, it's more superior because of the trough level. Actually, it's more effective rather than the IV. But they recommend to keep the baby MPO for that, actually, if he's on a high dose of Profen, yes. We stopped this practice, yes. Since we shift to paracetamol, we're not keeping the baby MPO anymore. And as Dr. Yasser mentioned, yes, actually, with this all studies, there is no one randomized controlled trial published regarding the PDA closure till now. It is non-inferiority trial, as you mentioned, yes. Thanks a lot.
Thank you, Dora. Thank you very much.
Thanks also. We can conclude the meeting. Thank you.
Thank you so much. Assalamu alaikum. See you next week, inshallah.